Okay, so we are now back, no? And we will now discuss our drugs for the lower respiratory disorders. Now, similar to what I told you before, I will use a specific conditions that will exemplify, why these drug classifications are needed. Okay. Now, in this instance, okay, these drugs are primarily used to treat what we call our COPD. Okay, COPD, and here's the catch, no, asthma. Okay, now there are two types of COPD, two common types of COPD. The first is our chronic bronchitis. Chronic bronchitis. Okay, and when we say chronic bronchitis, class, it refers to inflammation of the airways. Okay, inflammation of the airways, no? Another is your emphysema. Emphysema. You will learn about this class in your MS Gud. I guarantee that, no? Okay, so emphysema class. When we say emphysema, this is your damaged alveolar sacs. Ayan. Damaged alveolar sacs, no? Now, another thing, kining asthma class, this is a allergic response. Allergic respiratory response, no? Allergic respiratory response. Typically, class, in asthma, no, since these are what we call restrictive lung diseases. Typically in asthma class, what happens is there will be constriction of the airway. Ayan, constriction of the airway. Okay. Now, this can also be used for other restrictive lung diseases, like for example, pulmonary edema. It can also be used for pulmonary fibrosis, and this can also be used for lung tumors. Lung tumors that will restrict the airway. The thing you need to note about this, especially asthmatic patients. Okay, asthmatic patients should always wear, yan, wait sa class. Okay, should always wear a medic alert bracelet or ID band. Okay? The reason why is because in case of a sudden asthma attack, then we can intervene, because we now know their identity and we now know what to do. We now know that it is asthma, no? So these are the drugs typically used for specifically asthma and COPD, no? So let's start with our comparison first. Okay? So typically, asthma causes bronchoconstriction and dyspnea. Chronic bronchitis will cause dyspnea and mucosal secretions, while emphysema will cause bronchoconstriction and mucosal secretions. No, the thing about the thing you need to remember about this is all of these are what we call restrictive lung diseases. The problem is, since there is constriction or for example, since there is mucus secretion, there is a chance that there is impaired gas exchange and impaired ventilation specifically, no? So what happens is, since there is impaired ventilation, oftentimes there will be a retention of carbon dioxide. Okay? Now, specifically in asthma, I want to put this here now, as early as now, no? Wait. Wala. Isa ha? My pen is acting ko. Specifically in asthma, no? Since this is caused mostly by an allergen, no? Remember that an allergy triggers the release of histamine, di ba? Histamine. Now, the thing about that is this. If there is histamine class, if there is positive histamine, then it will, listen to me, inhibit what we call CAMP. Okay? When we say CAMP, this is cyclic adenosine monophosphate. Now, here's the thing you need to remember. CAMP is responsible for bronchodilation. Now, since asthma releases histamine, it will inhibit or stop CAMP. And if you stop CAMP class, then there will be bronchoconstriction. This is a very simple pathophysiology, no? So, that's the thing. Most of the time, our goal is to increase the CAMP in order to promote bronchodilation. Okay? Now, here is another summary of what's gonna happen. No? There are various allergens that may cause what we call our asthma. And this will stimulate the mast cells to release chemical mediators such as histamine, serotonin, and eosinophil chemotoxic factor of anaphylaxis, no? And leukotrienes. Okay, histamine itself. Now, because histamine is present, remember, as I mentioned before, histamine is present, there will be a decrease in CAMP, which will cause bronchoconstriction. Okay? And there will be bronchial edema and increased bronchial secretion, mainly because there is an activation of the other chemical mediators. Okay? So our job here is to stop. Let's talk about our first drug classification. So first is we have our sympathomimetics. When we say sympathomimetics class, they will mimic sympathetic nervous system effects. Okay? Specifically, class, what we are talking about here is an alpha and beta-2 adrenergic agonist. Alpha and beta-2 adrenergic agonist, not antagonist. So they are not blockers, no? The action of our sympathomimetics is that they will increase our CAMP, cyclic adenosine monophosphate, therefore causing bronchodilation by inhibiting the release of chemical mediators. So they will stop, no? They will stop the release of what we call our histamine. They will stop the release of our histamine. No? Tanawa ho? Inhibit, no? They will stop the release of our histamine, our, what else? Our serotonin, our eosinophils, no? And as such, no? For bronchospasms associated with COPD and asthma, beta-2 adrenergic agonists, selective beta-2, are given via aerosol because there are less side effects than non-selective. Okay? To further re-emphasize what I mean, ato ni siya balikon, you are very, very familiar with this example. Okay? Now, unlike our alpha and beta-1 blockers, instead of blocking the receptors, okay, they will activate these drugs, no? Our agonist will activate the receptors. Okay? Sige, let's talk about it, no? We have a few example drugs here. The first is our albuterol. Okay? Let's start with our non-selective. Selective, okay? These are beta-2. Beta-2 selective, which is our albuterol and our metoprolol. Okay? Now, albuterol class, I want you to put a big star on this. Okay, big star on this. This is for sudden asthma attacks. Asthma attacks. Okay, this is for sudden asthma attacks. This is for emergency asthma attacks. Ha? Listen to me, ha? If there is a sudden asthma attack, no? Now, how would you know if the patient is having a sudden asthma attack? A sudden asthma attack. Typically speaking, class, when you are assessing for asthma, okay, what you will hear first, listen to me, ha? What you will hear first is wheezing. And that means that the airway is narrowing airway. There is a narrowing airway, no? However, class, the thing you need to remember, lagyan mo yan ng malaking star, if no lung sounds, then that is already a closed airway. This is a major emergency. Okay, this is a major emergency and you need to notify MD na. Notify MD na. Usually, they will attach na the, what we call, tracheostomy, no? So, yan na siya, class, ha? This is how you assess. We give albuterol, class, as soon as wheezing occurs. As soon as wheezing occurs. And the reason why we give albuterol, okay, and I'm gonna put it here in blue, ha, because it has a fast and what we call it has a rapid action. I will use rapid. Mas ninot ang rapid nga word, no? It has a rapid action. And it has long duration. Long duration, making it very good as an emergency drug. Okay? Our metoprolol, it is administered, no? Either orally or by inhalation. Inhalation. Usually, if inhaled gani, class, it is for long-term use. Long-term use, no? With an MDI. When we say MDI, we are referring to a metered dose inhaler. Okay, inhaler, no? So don't worry, you will be taught how to use an inhaler when you discuss nebulization in your third year. Third year pa na siya, class, no? The thing about this is both of these drugs are given inhalation. The thing about these two drugs is that they are beta-2 selective. Meaning to say, listen to me, ha, their action is very simple. No? Since they are agonists, they will increase only your beta-2, the effect of your beta-2. And remember, the effect of your beta-2 is to promote vasobronchodilation, so they will increase bronchodilation. Diba? They will increase bronchodilation. So that is basically the effect. The effect is to stimulate the beta-2. Diba? And remember, the problem with your asthma, ha? Balik na. The problem with your asthma is that asthma has bronchoconstriction. So you want your lungs to dilate, diba? However, class, we also have what we call our non-selective. Tibutan diri sa ubos, no? Atong non-selective. Non-selective, no? Non-selective beta-2. Beta agonist. When we say non-selective, class, they will activate both beta-1 and beta-2. Okay? An example of a drug like this is our isoproterenol. Okay? This is usually given via MDI, meter dose inhaler. It can also be used using a nebulizer. And the best part is it can also be given via IV. Okay? Specifically for severe asthma attacks. Severe asthma attacks, di ba? However, this is infrequently given. Infrequently, Uy. This is what's wrong? Infrequently given due to potential side effects. Now, what do I mean by potential side effects? I hope na save to. My God. Wala ma-save. Sige. Ako lang. You can rewind it. I have completely wrote it down, no? What do I mean by potential side effects? Now, our isoproterenol, what it does is it will activate both beta 1 and beta 2. So we have our bronchodilation. Very good. However, our isoproterenol will also increase the BP, the heart rate, and contractility. Okay? So these are our side effects na. This is our side effects, no? Increased heart rate and BP. Okay? So what do we need to consider when it comes to this? Okay? Instruct the patient to limit the use of aerosol preparations. The reason why is because this can lead to tolerance and the loss of drug effectiveness. Okay? Another reason why is because repeated and frequent uses also cause rebound bronchoconstriction. So there must be a limit, no? And it depends on the dosing of the doctor. Assure the patient understands how to use their MDI plus spacer. Okay? A spacer class is an attachment that promote is a bad word. Assures proper dosage. Okay? Proper dosage. Okay? You will learn more about this in your third year. Sige lang. You will need to teach the patient how to use this, no? Mouth dryness and throat irritation are common side effects of our MDI inhalation, no? So what you need to do is you just need to address these side effects, no? Address these side effects, di ba? How do you address mouth dryness, di ba? You increase salivation by giving them sugarless gum. You ask them to drink fluids, no? How about throat irritation? You ask them to speak only when necessary, di ba? You ask them to take a throat spray, no? Like for example, ang pinaka-common nga throat spray is kanang bitong a composition similar to your sana siyang kanang murag candy. What do you call that? I forgot. Katong murag candy nga para sa throat. Wait, ato research. Strepsils. Yes. No? Strepsils. Strepsils. Yes, mga lozenge. No? There's also strepsils nga. There's also a preparation that is inhaled. No, you need to also watch out for tremors, dizziness, hypertension, tachycardia, and increased blood glucose. These are, as I mentioned before, side effects of our beta adrenergic agonist. Okay? Beta adrenergic agonist, no? Even selective beta adrenergics have residual activation of beta 1. Okay? So, lagyan mo yung malaking star, no? So since these are side effects, you just need to watch out for. You need to intervene individually, no? So next is our anticholinergics. Okay, now as I mentioned before, when we say cholinergics, di ba? When we say cholinergics, we are referring to your parasympathetic nervous system, or otherwise known as your rest and digest. Okay? Remember, so ito yung mga effects sa itong rest and digest. Number 1, it will increase urine output. It will increase peristalsis. Okay, what else? It will decrease heart rate and blood pressure, and this will also decrease our respiratory rate. Okay, this will increase what else? Defecation, paspas ka malibang, di ba? So with that in mind, okay, when we say anticholinergic, then this drug's job is to stop the cholinergic effect. Okay? To stop the cholinergic effect. Now listen to me, ha? Listen to me. I will now teach you what happens. If you stop the cholinergic effect, then what happens is this, no? Another thing that another thing I forgot. This will also cause bronchoconstriction. Okay, bronchoconstriction, no? Now the thing is, if you stop the cholinergic effect, then the effects are reversed. Okay? Because now, instead of, if you stop the cholinergic effect, instead of parasympathetic activation, there will be now SNS activation, or sympathetic nervous system activation. So instead of increased urine output, there will be decreased urine output. There will be decreased peristalsis. There will be decreased defecation. Okay? There will be bronchodilation. There will be a increase in heart rate and BP. And there will be an increase in respiratory rate. So, this is the effects of our anticholinergics. And we have three. Okay? We have our tropium, no? Our tropium class, this is long acting, and usually this is kunibutan diri very small, given via kini mo ni important part, no? dry powder capsule inhaler. Lagyan ko yan ng malaking star class, ha. You will during the time when you will be taught nebulization, no, and our use of inhalers, I want you to listen specifically for this one, dry powder capsule inhaler. This is a very common mistake that new nurses make. This lang kabaon sa paggamit ani, no? We also have our ipratropium. This is short acting, no? Ibutan diri class, short acting. Okay, this is short acting. Lagyan mo lang malaking star. Ipratropium bromide, no? This is used commonly for asthmatic conditions. However, class, this has systemic effects. So most of the time, class, they will have all of these effects, no? All of these effects. And we also have our ipratropium bromide plus albuterol, no? Otherwise known as your Combivent. Now this is used to treat chronic bronchitis. Yan, chronic bronchitis, no? Now, as I mentioned before, the action of anticholinergic is very simple, to block cholinergic action. Okay? Block cholinergic action, no? Wait a second. No? Remember, cholinergic action, no, is the activation of your parasympathetic, which will cause these effects, diba? So if you block these effects, no, it will reverse and it will activate the SNS and cause these effects instead. no? So mo ni siyang effects sa atong mga drugs. These are the effects of our drugs, no? Okay, let's continue. Now, what are our nursing considerations? Watch out for anticholinergic effects like dry mouth, urinary retention, constipation, and blurred vision. No, we have been repeating this before, no? The thing about that is if there is urinary retention, then you need to monitor patients' urine output and weights. Ayan, di ba? We already know that. Balik na lang no? For constipation, then we increase oral fluid intake and fiber consumption. Di ba? And we will encourage mobilization, walking, because walking will increase peristalsis. Okay? And then for blurred vision, then we already know, no? Fall safety risk. No? Fall safety risk measures. So, balik na class, no? Instruct the patient on proper inhaler use that is given already. Di ba? And then, monitor for signs of angioedema. Now, when we say angioedema, it refers to swelling of, lower layers of the skin. Okay? Typically, this is associated with the presence of hives. Okay? Hives. No? Now, why do we note or monitor for angioedema? Now, angioedema class is a sign of toxicity. No, toxicity. No, it is a sign of toxicity. Okay? So, if this ever comes up, you need to notify the doctor. No, stop and then notify the doctor. That's always our balik na tayo. So we have been repeating that over and over again. Di ba? Over and over again. Di ba? Next is our methylxanthine derivatives. What it does is it will relax smooth muscles of the bronchi, bronchioles, and pulmonary blood vessels by inhibiting phosphodiesterase. Okay? If you inhibit phosphodiesterase class, it will increase the clamp and increase bronchodilation. If you remember, di ba, muna siya that is the cause of our bronchodilation, our clamp. So, these methylxanthine derivatives, these are bronchodilators. Ayan, bronchodilators itself, no? There are 3 examples, class. We have our caffeine. And when I say caffeine, I am referring to the caffeine that is found in your coffee. No, that is a methylxanthine derivative or a xanthine derivative. We have our aminophylline and our theophylline. Now, the thing you need to remember about all of the drugs is commonly theophylline ang the one that they use. We commonly use this, no? Now, theophylline, and I want you to remember this, it has a narrow, it has a narrow therapeutic range. A narrow therapeutic range, typically around 10 to 20 micrograms per ml, no? 10 to 20, okay? Oftentimes, if it is greater than 20 micrograms per ml, then it will cause our toxic effects, no? Toxic effects. Now, the problem is there are a variety of adverse effects. Okay? There is a variety of adverse effects. Sige na, ako i-discuss later. I will discuss later, no? And because of the risk class for toxicity, oftentimes we only use this, no? This is used for maintenance of stable, wrong. Chronic stable asthma and COPD. Okay, maintenance ra ni sa class, no? Put a big star on it. We don't use it for acute attacks. We don't use it for acute attacks. Okay, so what are the adverse effects of these drugs? We have dysrhythmias, no? So, if you are gonna watch out for this class, if there's a possibility for dysrhythmia, remember, attach an ECG. Okay, attach an ECG. Convulsions or seizures, so what you need to do is seizure precautions. Okay, seizure precautions. Now, I will for the interest of everyone, no, seizure precautions are a lot, no. I have mentioned this before. I have discussed this in your fundamentals of nursing. However, this will be discussed in your psychiatric nursing. So, I will put a big star on that class, ha. Put a big star on that class. Listen to what we mean when we say seizure precaution. And then cardiorespiratory collapse. That's the worst, no? Respiratory and cardiac failure, no? This is contraindicated for patients with seizure disorders because it might cause seizures. Remember, ha? Our methylxanthine. Okay? Methylxanthine derivatives can cause, no, tanawa diri ako nagibutang convulsions, no, convulsions, okay, which increases the risk for seizures. So do not give this to a patient with seizure disorders class. Okay, theophylline can also cause hyperglycemia and increase clotting time, so you need to monitor patients blood glucose, okay. For hyperglycemia class, I think the thing that they are gonna use, no, another thing that you're gonna consider about hyperglycemia is you need to attach an ECG. Okay, attach an ECG. And then for clotting time, there is a risk for bleeding. Okay, there is a risk for bleeding, so you still need to consider those. Okay, wait sa class, ha. Nasa ko'y pagmuna. So yan guys, sasabay ka ba? Papasa ka ba? Sasabay ka ba? Papasa ka ba? Okay, next is this classification, our methylxanthine inhibitors, no? Methylxanthine derivatives, the inhibitors man, no? Must be administered slowly with an infusion pump because rapid administration can cause dizziness, hypotension, and or severe bradycardia. Okay? Severe bradycardia. So, slowly with an infusion pump. Okay? Avoid caffeinated products when taking this drug because methylxanthines have a mild diuretic effect. No? So, the tendency among good class is caffeinated products like coffee or energy drinks, they tend to increase your diuresis. No? And you don't want to keep on increasing your diuresis by taking caffeine with methylxanthines. Okay? So, it is best to increase the oral fluid intake. Keep on drinking water. And another thing is, since caffeine is also a methylxanthine, you don't want to double down on a specific type of drug, no? You have to note common drug interactions, and I want to put a big star on this class. theophylline has a lot of drug interactions. Okay? First is theophylline okay, increases digoxin toxicity risk. So what you need to do is prepare the antidote for digoxin toxicity, which is prepare digibine. Okay? Another name for digibine class is your digital. Ano naman to class? Digital immune fab. Digital immune fab, di ba? Sige, what else? What else, no? No? Another is this, phenytoin. Phenytoin, this is an anti-seizure drug. Anti-seizure drug decreases theophylline levels. Okay? Another is theophylline. And no, not N. It's not this N. Plus beta adrenergic agonist can cause cardiac dysrhythmia. Okay? Lagyan mo yan ng malaking star class. It's very good. Also, lastly is theophylline decreases the effect of lithium. Okay, lithium class is an anti-manic drug. Anti-manic, no? Now, what do you need to do, class, for all these drug interactions? Now, what do you need to do for all these drug interactions? Notify MD if present in chart. So, if you check the chart and you see there, let's say, for example, theophylline and digoxin, okay? Let's say, for example, you see there theophylline and a beta-adrenergic agonist. Then you tell the doctor, Doc, na ay theophylline, there's theophylline and there is a beta-adrenergic agonist in the chart, no? So, this might cause drug interactions, okay? So that they will, what we call, change the prescription, okay? Remember, class, nurses, as nurses, we cannot change the prescription, We cannot change the prescription. However, we are responsible for these drug-to-drug considerations, drug-to-drug interactions. Okay? So, na siya. Now, here's the thing. As I mentioned before, it has a narrow therapeutic range, no? And typically, drugs with a narrow therapeutic range has an antidotes. Okay? Has an antidote. Now, what is our antidote, class, for theophylline? Okay? What is our antidote for theophylline? Technically speaking, class, the antidote is there's none. No? There is none. There's a lot of studies that say that the antidote for theophylline is activated charcoal, similar to your what was the name of that drug? Kalimut na ako, no? It's activated charcoal, but there's no substantial evidence. So as of right now, no, there is technically no antidote. As of right now, there is technically no antidote, no? Sige, next is our leukotriene modifiers. No? Now, leukotriene modifiers, what it does, no. Before we discuss, let's talk about leukotriene first. Now, leukotriene, when activated, okay, specifically this is activated during asthma, okay, cystinyl leukotrienes promote inflammatory changes in the lungs. Remember, if I go back to the top, tanawa, if I go back, mast cells will release leukotrienes. Okay? Mast cells will release leukotrienes. Now, once they are released, class, what they do is they will promote inflammatory changes. Okay? This will cause increased eosinophil chemotaxis, increased mucus production, and air wall edema. All of these effects cause what we call bronchoconstriction, which is the main problem in asthma. Diba? That is the main problem in asthma, no? Lagyan mo yan ng malaking star. Now, when we say leukotriene modifiers, they will block the leukotriene receptors and block the synthesis of leukotriene. So they will stop production of leukotriene and block receptors. Okay? They will block receptors. Okay? So, if you block the leukotriene class, there will be no inflammatory changes. There will be no eosinophil chemotaxis. There will be a decrease in mucus production, and there will be a decrease in air wall edema. Airway wall edema, no? So instead of bronchoconstriction, class, what will happen is they will bronchodilate, and we want that, diba? Bronchodilation, no? Gusto ta na, class, we want that, no? So they are very effective at decreasing the inflammatory effects of asthma. Okay? However, they are used for prophylaxis and for chronic patients only. They should not be used for what we call acute asthmatic attacks. Not be used for acute asthmatic attacks. Now, when we say prophylaxis, class, what I am referring to is these are usually taken before an asthmatic patient, okay, exercises or increases effort, or if positive presence to allergens. Okay? Let's say, for example, class, I am asthmatic and I am about to run. Padung kung mudagan if I am asthmatic. Now, if I run with asthma, there is a chance that I might get an asthma attack while running. No? Or let's say, for example, if I am about to go to a dusty place, a bukid na lugar, there is a very high chance that I will get an allergen and trigger my asthma attack. No? So, typically, what I need to do is I will need to take a leukotriene modifier because this is a prophylaxis. This will prevent, ako na lang ibutang diri class, the big P word, prevent an upcoming, not an upcoming, prevent a predictable asthma attack. Okay? They are not used, listen for, they should not be used for acute asthmatic attacks. Okay? Typically speaking, if acute asthmatic attack kani class, if they are talking about acute asthmatic attack, no, the drug of choice for acute asthmatic attack is albuterol. As I mentioned before, ako na ibutang in class, I already put that class. I hope you remember that, albuterol for sudden asthma attack, no? So that's the reason why they are very, very important. Okay? Remember that. Wag mong kalimutan yan. So, our example for these drugs is our Montelukast, Zafirlukast, and Zilueton. No, Zilueton. Now, what do we need to consider when it comes to these drugs? Number one, advise the patient that if allergic reaction occurs, the drug should be discontinued. Okay? Allergic reactions like, for example, class, rashes. Diba? Rashes. What else? Dyspnea. No? Dyspnea. What else? No? The presence of hives. Kana. No? Instruct the patient to avoid St. John's wort. I know you already know, or you already heard about St. John's wort before, because this will decrease Montelukast effect / also decrease your concentration. So this will affect the dose. That's why avoid St. John's wort, no? After opening the packet, this must be administered within 15 minutes because this can spoil the dosing, no? This can spoil the dosing. And then you need to monitor the patient's liver function test. Okay? When we say liver function test, mo to siya ang atong AST and then our ALT. Not because this is hepatotoxic. This is not hepatotoxic technically speaking. Zafirlukast and Montelukast increases the AST and ALT. So, the MD must consider this as a possible pathology. Okay? He must consider that, no? A reaction to the drug. And I think that's it, no? So for your further reading class, I want you to read on cromolyn, sodium, and nidocromil and mucolytics class. There's a very short class, no? Less than 1/4 of the page in your book. Or basta I know that both of these drugs are found in 1 page of your book. Charo. Grabe na lang hindi mo katapulan, kung hindi na lang hindi mo basahon, no? So yeah, na gusto ko nga, since this is asynchronous, I want you to do some work as well. So read on those. The reason why I want you to read on those is because once we go back to face, okay, we will immediately have a quiz on respiratory drugs. Ayan, and I will include all of these classifications, no? Quiz on respiratory drugs. And then after that, immediately after the quiz, we will have our drugs affecting the autonomic nervous system. Ayan, no? So, that is what's gonna happen once we go back to face. Sige na, class. And that is it for this discussion, no? I hope you are doing well. If you have any questions, please don't hesitate to message me. Okay? And with that, thank you.